Hi everyone, and welcome to the GREX curriculum on exercise and chronic kidney disease. This is meant to be a training program for fitness and health professionals, and my colleague and I will be giving you the first module on the pathophysiology of chronic kidney disease. So my name is MacRae, and I'm a professor of medicine at the University of Calgary, and my colleague is Dr. Clara Bohm, who's at the University of Manitoba. So our learning objectives for this module are threefold. First is, we hope that by the end of it you'll understand what the basic functions of the kidney are. Second objective is to learn about the different stages of chronic kidney disease and how they may impact on exercise and physical activity. And then finally, our objective is to discuss the complications of late-stage kidney disease that are relevant to you. So, our outline, we plan to cover all of the following in the next few minutes. Focusing on the kidneys, epidemiology of kidney disease, what medical problems specifically are associated with CKD, and to review some of the complications, and then finally physical function and activity. So the kidneys are highly underappreciated. They are remarkable, tiny little organs that are about the size of your fist that sit under your rib cage, and they are responsible for filtering 120 liters of your blood every day. And by doing so, they remove the waste products and they create about 1 to 2 liters of urine every single day. They're very important for regulating the salt and water balance in your body, and they're really important to control the acid and base balance as well. But people may not actually realize that they also are involved in producing hormones, and vitamin D is actually activated by the kidney, and without that, this has significant impact on the bone health. Erythropoietin is a hormone that is also made in the kidney, and it's really important to cause bone marrow to produce blood cells. And then finally, renin is a really important hormone that's involved in regulating blood pressure, and it too is controlled by the kidney. So, about 10% of people actually live with kidney disease. In some areas of the world, this number is even higher. The leading cause of kidney disease really is diabetes and or high blood pressure. There are some other common causes as well, and some of you may have heard of polycystic kidney disease, which is a genetic and usually familial kidney disease. Glomerulonephritis, which is usually autoimmune and related to inflammation in the kidney. There are a few other inherited kidney disease states, and also obstruction. So things like an enlarged prostate or cancer that might block either the bladder or the ureters, leading tubes leading out of the kidney. Risk factors for kidney disease include diabetes, high blood pressure, and heart disease. Commonly smoking and obesity, as well as family history, and certain ethnic groups have a high risk of kidney disease. So we think about kidney disease in terms of stages or severity of kidney disease, with stage 1 being normal or very mild kidney impairment, and stage 5 being kidney failure. We typically think about the stages in terms of the percent function, or how much glomerular filtration rate there is. And again, with stage 1, normal, greater than 90 mils per minute. Moderate stage 3 being anywhere from 30 to 60 mils per minute. And severe would be defined as between 15 and 30. And stage 5, or kidney failure, is when the kidney function is less than 15 mils per minute. This is a time, as the kidney function approaches less than 10, this is when kidney replacement therapy, such as transplant or dialysis, are typically started. And you can see here the different categories of kidney disease, again ranging from stage 1 to 5. you really don't have that much effect on the ability to exercise in the early stages of kidney disease, but in the moderate kidney disease state, so stage 3, and in the second half of kidney stage 3, so 3B, that's when you start to have an impact on exercise. In stage 4, or severe kidney disease, that's when the exercise capacity is quite significantly reduced. And for folks with stage 5 kidney failure, that's when the ability to exercise is really severely impaired. So this slide highlights some of the common medical problems and conditions associated with kidney disease. High blood pressure is incredibly common, and it's a result of basically altered regulation of your blood vessels. So poor vasoregulation and blood vessel constriction is very typical in chronic kidney disease. As mentioned, patients often end up accumulating salt and water, which leads to fluid and volume overload, and this also has an impact on resulting in high blood pressure. Cardiovascular disease is incredibly common in this population. So heart disease, peripheral vascular disease, cerebrovascular disease, all of these conditions are seen in kidney patients. And in fact, cardiovascular disease is the most common cause of death and hospitalization in this population. Cognitive impairment is also fairly prevalent, although the mechanism of this is not clear, and it may be related to the underlying vascular disease, but it's thought there may be some other conditions associated with kidney disease that contribute as well. So once a person reaches kidney failure, or less than, or stage 5 kidney disease, and they start to accumulate some symptoms, so again, usually when the percent kidney function is less than 10, that's when we start talking about starting on renal replacement therapy. The most common type of renal replacement therapy is hemodialysis, and typically it is in-center hemodialysis, where a person goes to a center 3 times per week to get hemodialysis for 4 hours each time. Hemodialysis, you can see here in this picture, it's an example of a hemodialysis unit with a patient on hemodialysis, and really just meaning that the blood is removed from the patient and filtered through a machine and before returning back to the patient. The other kinds of dialysis would include home hemodialysis, so doing this but doing it at home instead of having to come to a center 3 times per week, and peritoneal dialysis is another option where instead of using a filter attached to a dialysis machine, you actually use your own peritoneal membrane. So the peritoneal membrane lines the surface of the abdominal organs, and across this surface is how you can actually do dialysis. So a patient would have a dialysis catheter placed below the umbilical area. It goes into the pelvis, and then fluid would be placed into the abdominal cavity, and dialysis would occur across the peritoneal membrane. This is a much simpler type of dialysis. A patient can learn to do it within a few days, and it's much more flexible, allowing more freedom with travel and scheduling. Home hemodialysis is often taught to patients over the course of about 6 weeks. So patients would learn about what dialysis is, how the dialysis machine works, and how to troubleshoot and maintain their hemodialysis at home. So typically a 6 or more week for training for a patient to be comfortable to go home to do their home hemodialysis. And the last type of kidney replacement therapy, and the best, would be that of a kidney transplant. This offers the best quality of life and the best outcomes for patients if they are in fact eligible for a transplant. Transplant can be provided in 2 ways. One is through living, which may be related or non-related donations, and the other is from a deceased donor or cadaveric donor. There are many complications that occur with late-stage kidney disease. And these are several of them. So because the kidney is an important source of creating erythropoietin, which makes blood cells, anemia commonly occurs. And this typically happens when the kidney function is less than 30 mils per minute. As we mentioned earlier, high blood pressure is a very common side effect of kidney disease because of the abnormal renin production and the salt and water retention that occurs. Bone abnormalities are also incredibly common, and this has to do not only with the abnormal ability to activate vitamin D, but also because of the gradual accumulation of phosphate, since the kidney is no longer able to excrete all of the phosphate that one ingests in a typical diet. This, in combination with the abnormal vitamin D, results in activation of the parathyroid gland, and which is responsible for regulating bones and results in significant increased risk of fractures, bone pain, osteoporosis, and muscle weakness as well. In addition, there are other metabolic abnormalities that occur. Specifically, the kidney is less able to excrete potassium, and also tends to hold on to a lot of acids, and so a metabolic acidosis state occurs. Fluid overload, as indicated earlier, is extremely common. So patients will often have peripheral edema, fluid in their lungs. Cardiovascular disease in itself it increases as the kidney function decreases, and it's thought that kidney disease itself is a risk factor for the development of cardiovascular disease. And it's thought that it's not related to just the traditional cardiovascular risk factors of diabetes and high blood pressure, but there may be other non-traditional risk factors, such as just the presence of uremia or elevated urea and other risk factors. And finally, infections are incredibly common, and that's because of an altered immune system which occurs in chronic kidney disease. But it's also a result of the fact that patients have catheters placed into their body, which allows for a breach of your natural immune fighting abilities, and therefore increased risk of infection. For folks who have a transplanted organ, transplant medications themselves will suppress the immune system, all of which will result in an increased risk of infections. So there are many medications that a typical kidney patient has to take in order to combat all of those complications that arise. And in fact, it's thought that there are at least 12 medications per day. So it's not unusual for our patients to be taking blood pressure lowering medications, as well as, since heart disease is so prevalent, many of them are on a host of other cardiac medications like aspirin, beta blockers, cholesterol medications. Diabetes medications as well are very common in this patient population. And for the folks that are on dialysis, they tend to take a lot of other medications to combat some of the symptoms that occur. And so anti-nauseous, anti-itch medications like antihistamines. And then because of anemia being so prevalent, folks are on erythropoietin injections and often oral or intravenous iron to build up their blood cells. Because of the body's inability to get rid of phosphate, which is found in all of our food, many times we have to add in a calcium-based binder, which the idea is to take these binders during meals, and the calcium will bind the phosphate and get excreted through the gut. There are other types of phosphate binders that don't involve calcium, but they do all significantly add to the burden of medications in this population. And for the patients who've received a kidney transplant, they're typically on at least 2 specific immune suppressive medications for the rest of their life. So again, all of this really contributes to polypharmacy, and with the increased number of medications, this significantly increases the risk of an adverse event and increases the risk of hospitalization. So I'm going to pass it over to my colleague, Dr. Bohm, for the next section.
Some of these medications are used to treat symptoms that are common in CKD stage 4, 5, and dialysis, so the later stages of CKD. These symptoms are very burdensome and difficult to treat and often under-recognized and underreported. About 80% of people on dialysis have at least one symptom, but really most people have an average of 6 symptoms. The most common symptom is really fatigue, and that occurs in the majority of people, and it is very difficult to treat. You can see the other symptoms here, but many of them are also difficult to treat, such as itch, cramping, restless legs, pain, GI symptoms, and particularly abnormal taste and decreased appetite. There are cognitive changes and symptoms, including what people call brain fog, mood symptoms, symptoms of anxiety, depression, poor sleep, and decreased libido. And then there are other symptoms like swelling, shortness of breath, dizziness, chest pain, which could be a result of the dialysis treatment itself, could be a result of kidney disease and fluid overload, or could be related to other comorbidities that are not related to dialysis, such as heart disease and lung disease. I think what's really important to recognize is that we don't have good treatments for many of these symptoms, and that dialysis, although it does clear toxins from the blood and help the body get rid of water, actually really doesn't usually make symptoms better. In only 25% of people do symptoms get better once they start dialysis. In 50% they stay the same, and in 25% they actually get worse. In addition to symptoms, there are several conditions that are quite common in late-stage CKD. Frailty refers to a state where an individual is unable to adequately respond to a physiological stressor because they just don't have the resilience to do so. An example of this would be an individual who develops pneumonia. And compared to someone who is not frail, this individual gets really quite sick, has to be admitted to hospital. It takes them really long time to recover. They're bedbound for that time, they lose physical function, and as a result of this pneumonia or physiological stressor, they never actually return to their baseline state. There are many different ways to diagnose or identify frailty. One of the more common methods was developed by Freed, and it consists of 5 criteria. And in order to be diagnosed as frail, an individual has to have 3 or more of these 5 criteria. You can see that they're listed on the slide, but they include unintentional weight loss in the last 6 months, self-reported exhaustion as reported by answers to 2 questions from a common questionnaire for depression, slow walking speed as measured by 4-meter gait speed, weakness usually measured by grip strength, and low physical activity often measured with self-reported physical activity questionnaires. Sarcopenia is a state with progressive and generalized loss of skeletal muscle mass and skeletal muscle function. Both frailty and sarcopenia are common in older adults and an increase in prevalence as we age. But the prevalence in people with CKD is even higher than in older adults. And for each age category, those with CKD actually have much higher prevalence of these conditions than adults in the general population of the same age without chronic kidney disease. Frailty and sarcopenia also are more common in later stages of chronic kidney disease as kidney disease progresses. Frailty and sarcopenia are associated with decreased quality of life. They affect one's ability to stay on home dialysis and increase the risk of failing home dialysis and having to go back to in-center dialysis. They're associated with low levels of physical function and increased adverse events such as increased cardiovascular events and an increased risk of death. The higher prevalence of frailty and sarcopenia in people with chronic kidney disease is likely, at least in part, related to abnormal muscle structure and function that is seen in chronic kidney disease. These abnormalities include muscle atrophy, decreased muscle strength, decreased physical performance and endurance, and decreased physical function. We don't really know what the causes are for these abnormalities, and reasons are still being identified. But we know that chronic kidney disease is an inflammatory state, and there is increased oxidative stress and insulin resistance with chronic kidney disease. And all of these things can lead to abnormalities in muscle structure and function. We also know there are abnormalities that have been observed with mitochondria in the CKD state. This includes reduced mitochondrial volume density and reduced mitochondrial efficiency. Ultimately, progressive decline in kidney function leads to low muscle density, low gait speed, and a faster decline in muscle strength over time. And as I've mentioned with frailty and sarcopenia, what we see is that these abnormalities worsen as kidney disease progresses. So how do these abnormalities relate to physical activity? Well, physical activity also declines with worsening kidney function. And we know that inactivity leads to heart disease, diabetes, and high blood pressure risks in the general population, and the same goes for people with chronic kidney disease. We also see that low physical activity in people with kidney disease is associated with higher death rates and higher symptom burden. But the good news is that exercise does seem to improve some of these outcomes. So exercise seems to improve endurance, muscle strength, and physical function. And this benefit has been shown in almost all stages of chronic kidney disease. Exercise may improve quality of life, but the studies actually differ in their results, and that partly may be because of the different ways that quality of life are measured. Physical activity and exercise do improve some chronic kidney disease symptoms, such as restless legs, symptoms of depression, probably cramping and fatigue, and possibly other symptoms, but there aren't really that many studies looking at all the symptoms. Other possible benefits of exercise include a lower heart disease risk, improving blood pressures, and better dialysis. This figure, developed a number of years ago now by Dr. Johansson, very eloquently depicts how the low physical function and low physical activity levels in people with chronic kidney disease can lead to increased disability, increased comorbidities or worsening comorbidities, and then how that relates to worsening adverse outcomes or higher risk of adverse outcomes such as hospitalization and death. And what I really want to highlight here that Dr. Johansson has shown is that exercise has the potential, and in some cases has already the demonstrated benefit, to impact multiple points on this vicious cycle and potentially improve not only physical function, but other things such as symptom burden, comorbidities or severity of comorbidities, and potentially ultimately decrease the risks of mortality and hospitalization and other adverse events. In conclusion, chronic kidney disease is common. Physical function and physical activity levels are low in people with chronic kidney disease and worsen as CKD progresses. Comorbidities such as sarcopenia, frailty, and heart disease, as well as symptoms, are common in people with chronic kidney disease and again increase in frequency as kidney function declines. The good news is that exercise and physical activity can help mitigate some of these adverse aspects of chronic kidney disease. Congratulations, you've completed Module 1, Pathophysiology of Chronic Kidney Disease. Next up, Module 2, Keeping the Person Forward.
Take a moment to evaluate your knowledge with the following self-assessment questions. Feel free to pause the video at each question to identify the correct answer. The correct answers can be found on the GREC's website.